mood lighting on here, and maybe a little too much. So, but okay, and so we're going to continue on here. As Steve said, I'm Tom Porter from the University of Nebraska Medical Center, and Steve and I have been doing contrast since the 80s, 1980s, that is. And so we've seen a lot of development of the field, so we're very excited about that it's really reaching a point where I think most people are recognizing its value, whether it be CT people or MRI people. I think they're realizing now ultrasound enhancing agents, the safety and the efficacy of these are really helping, not just necessarily reducing their number of procedures, but as Steve pointing out, maybe really getting a lot more things answered for us with the first study that we don't have to keep doing repeat studies for. And so the objectives of this, we kind of changed the order a little bit here because I think we're going to have the sonographers present after lunch to kind of give us, so that we can I'm going to show you a lot of cases here to mainly emphasize the imaging techniques, because as we said, this technique is approved by the FDA for left ventricular pacification, and we still don't do that very well. We're just learning techniques that with the imaging that are helping us do a better job of seeing the microbubbles and enhancing these borders so that we're getting true volumes, not fake volumes at end diastole and end systole, and being a lot more confident in our interpretations of regional wall motion. And you'll be literally, I think, as I was, shocked to see some of these wall motion abnormalities that we're missing, even with what appear to be relatively good windows. And that ultrasound enhancing agents help us, especially in the situation of evaluating patients with chest pain, evaluating patients with shortness of breath, and seeing these abnormalities that would otherwise go undetected and lead to the physicians being misled a little bit as to how much coronary artery disease or cardiomyopathy were playing a role in why these patients are in the intensive care unit or why they're having shortness of breath. So, and then I'll show some clinical trial data where we have prospective randomized trials now that have looked at the value of very low MI imaging. Now, what do I mean by very low MI imaging? I'll explain that because it's very important that we use that term, probably not the best term to use, but we use that term in the guidelines to emphasize a technique that is probably the best way to image these microbubbles, because most of the time you think of using just harmonic imaging for detecting the microbubbles, but that's really not a real good technique to use. I'll show you why. And then some value of it in microvascular disease. Now, as we said, the typical response of a microbubble, as Steve pointed out to you, in response to an ultrasound beam is that it produces harmonic and what we call nonlinear responses. And that basically what we mean by nonlinear is that we see these little responses here at the second and third harmonics of the frequency we're transmitting at. For example, if you're transmitting at 1.3 or 1.5 megahertz, you're receiving at 3 megahertz. And the nice thing about that is that's pretty much exclusively from the microbubbles. But there's also a nonlinear response you can see here in the fundamental frequency. And if you look at it in terms of its amplitude, here's the energy of that response or the brightness of that response that you're going to get. You can see it's about twice the size of the second harmonic. So when you're using harmonic imaging, you're getting this and you're saying, wow, that's great. But it doesn't, it's not a whole lot of contrast there, and it gets less and less as I go to a lower and lower MI, which I'm supposed to do, as we pointed out, in terms of getting a contrast from the microbubbles. But that's because we're missing out on a much higher response here. Ultrasound enhancing agents have this nonlinear response, and it's in the fundamental frequency as well. Now, when we originally had the availability of contrast agents, we were using this, what we call low MI harmonic mode, and that's pretty much on all the systems have a harmonic. In fact, almost all of our transducers are harmonic, right? Even when we're using it for non-contrast imaging, we're using a harmonic transducer. You're transmitting at something on 1.8, 1.6, 1.5, depending on what manufacturer you're using, or even down as low as 1.3 or 1.2 now on the Epic and megahertz. But they're receiving at harmonics of that frequency. And as I said, that response from the microbubble at a low MI is this right here, this little thing right here. You see, you get a fairly good response, very little from the tissue. That's good. And so you have a fairly reasonable contrast response, but it's at a high frequency. If you look at the fundamental response, you get a much bigger response, and I'll show you that in a second. So this is a patient we just did in January. It was a typical afternoon ICU patient, 4-chamber view. The question is, they're here, they're on a ventilator. What's the ejection fraction? As Steve pointed out, probably our most common reason. And of course, what's regional wall motion? Well, as you can see here, when we first tried using low MI imaging at a 0.2, you probably all can't see that. I can see that's 0.22 mechanical index. You get some opacification here of the apex, but I think one thing you can notice is as you get further down here, it gets less signal from the cavity, less signal from the myocardium.
Oh, Tom, can
Yes.
I just point out something too? You are here. This is 1.6 and 3.2.
Right. So you're transmitting at 1.6 and you're receiving only at 3.2. As we said, that's pretty good. I just showed you that little signal. But we know one thing, that 3.2 megahertz in a 200-pound patient is that means a lot of this back here you're not getting much signal from because it attenuates. Now, if we switch to a very low MI imaging technique, which looks just at this fundamental response, which is that is a much bigger response than what we see in the harmonics, and cancel out the tissue signal. Now, one of the nice things about a multi-pulse, very low MI imaging technique is, yes, we get a lot of signal, as I just pointed out here, but we also have a lot of tissue signal, right, even at a low MI. But you can cancel that when you use a multi-pulse technique, like amplitude modulation or contrast pulse sequencing or some of the terms that are used by manufacturers. But the real purpose of that is to cancel out any kind of linear activity that comes from tissue. And we use a very low mechanical index, so the tissue is not producing much signal anyway. It's just the microbubbles producing signal. That's what these techniques do here that are outlined in red here. They have either alternating amplitude or alternating amplitude and phase, like contrast pulse sequencing. So they allow you in the fundamental frequency to see the nonlinear response, which, as we said, is much bigger. They cancel out any tissue signal, which was quite low at that very low mechanical index or very low mechanical index imaging setting anyway. And now we don't have the problem with attenuation, right? Because now we're imaging at 1.8 megahertz, for example, and receiving at 1.8 megahertz, just like Steve put it out there. Instead of transmitting and then receiving at a harmonic frequency, which attenuates, now we can receive at that frequency we transmitted at and get all that bright contrast and much less attenuation. And what does that look like? Well, here's just by pushing a button over to the amplitude modulation here, which was on an IE33, you can see now we see good contrast just about everywhere, okay? Not just at the apex, but good contrast way down here in the basal segment. So we can look at basal segment wall motion and regional wall motion as well. Yes.
When you go back to that, again, can you point out your frequencies?
There you see it's transmit at 1.8 megahertz. It's very hard to see, but it's transmitting at 1.8 megahertz and receiving at 1.8 megahertz.
All right.
Here,
now, this is software, Tom, that is not just simply your MI is low.
the MI is at 0.18, right here, 0.18. See that? There it is right there.
But this is additional software in all the machines.
All the machines,
that's
yes.
not standard.
Well, it's apparently not standard, but it's been around since 2000.
But does
so
everybody, my question to the group here, are we all using what Tom describes as very low MI software, not just turning the MI down?
Yeah, this is what happens
This
when you
is
turn
really
the MI
important.
down and use harmonics.
Can I pass this around?
So,
Comments?
and this is what happens when you use that very low MI imaging, which the companies manufactured way back around 2000, thinking, oh, this is going to be for perfusion imaging. But it was not. It turns out it's the very optimal technique for LVO. And because why? Well, because now we're picking up abnormalities that we could never see out here in the anterolateral, basal to mid anterolateral segments. I'll show you examples. But that's why our guidelines changed all the way back in 2014 when we issued the sonographer guidelines. We said, in this setting, a very low MI multi-pulse sequence scheme, if available, should be used. And use a little flash high MI impulse to clear the myocardium so that you optimally can see regional wall motion. Why? Because it reduces microbubble destruction. With that very low MI, you're down to 0.18. But you don't, the problem if you just use harmonic in that setting is you get less and less signal. Well, when you use that multi-pulse sequence in the fundamental domain, you still get a lot of signal, just very little tissue signal. And it helps us for the first time get rid of that problem that we've had for a long time, attenuation of the basal segments. So we can see apex and basal segments. So we get enhanced contrast that's optimal for LVO and perfusion should you want to do it. But we're talking about the FDA approved indication here right now, okay? Just the LVO application here to optimize that. So this is what we do day in and day out. We do about 15 to 20 stress echoes a day, dobutamine exercise, and then about 30 regular echoes using the same technique you see here. We administer this is right before flash, this is right after flash. So now we have optimal endocardial border delineation of all segments, and then we can see it throughout the cardiac cycle, as you can see here. Boom, like that, right there. So then we look at that. That allows us to see the regional wall motion after that high MI impulse so that we can really see the regional wall motion.
Just one question too. Did you start with dobutamine when you're ramping up perfusion and then move to treadmill?
Yes.
Okay.
That's exactly the sequence.
Because there were some questions on where do we start?
And some do bicycle with it, but treadmill's the universal one that we use. It's a little tougher, but if you're using this technique in a real-time fashion like this, the sonographers get pretty good at it, get very good at it, because they're used to already doing this rapid acquisition, within a minute. They're just adding now some high MI impulses. So typically we'll train the patient a little bit beforehand, while they're getting these images to be taking some deep breaths in and out so that they can hold their breath for just a couple of seconds when we apply that flash high MI impulse. But for dobutamine, it's very helpful. Here's just some routine examples. Now, I'm going to show you first just some resting LVO examples for people that were referred for stress echoes, okay? This is a patient that we saw in the ED on a Saturday for chest discomfort. Yes, we do stress echo on the weekends to answer to Steve's question there. Unfortunately, these images are not playing again. They were playing a little bit when we tried them. They always play when IT's up here, but then when I'm up here by myself, they stop playing. So why do they? Okay, so now this one. So I can go out of this and play them here. I always have to play them here. Yeah, they play outside of the slideshow for some reason, but they don't play. I'd like to play these. Yeah, so they play for a few seconds. Now, see, now watch, he'll go away, and these will stop. It's a very close correlation. But I tell you, just stand right here, okay? So, but I'll play these right here. But okay. So, what do you guys think of regional wall motion there? And do we think we need contrast at all for this kind of case? Okay, the anterolateral wall may be a little bit poor, but you're trying to say, well, you're trying to be nice to us and say, well, yes, I would use contrast, right? But if you were really seeing this patient, there's a patient that had some methamphetamine use in the past, having chest pain. Trope was 0.11. Trope was a little elevated. Okay, and here's the 2-chamber. I'll play this in here. Like I said, we'll have to stay in this mode just because it's. What do you think of the inferior and anterior wall there? This, we probably should have turned a little bit more. You still see a little bit of right ventricle there, but inferior, a little concerned about that. Okay. Okay. Well, our sonographer knew that I was reading. Sometimes they decide when it's a real good window like this to whether, depending on who they attend, because they know that we'll always ask for contrast in certain settings. When it's evaluation of chest pain, we tell them we really need contrast because we need to be absolutely sure. I agree with you. I don't think the apex is well visualized. I don't think the anterior wall is well visualized. But it gets back to that compacted versus non-compacted border a little bit. Because I'm going to go now I'll just put these side by side with now here is the 4-chamber again that we looked at previously. And here's the 4-chamber in the same patient with the very low MI imaging. Now what would you say? Look at it a little bit. Just wall motion. We're not talking about perfusion. They're just wall
You
motion.
can see everything better now, that's all.
What about here?
If we don't see more than 2 segments, we are automatically using the contrast
Good.
at our exposure.
Then how do you use it?
I'm sorry,
Then how do you use it? Do you use harmonic or do you use this very low MI?
low MI,
Low MI being low MI harmonic?
low MI harmonic.
Harmonic. Okay, so
We even go down way 0.07.
but see, then don't you lose a lot if you're using harmonic? Don't you lose a lot of contrast?
No.
Okay, because the very low MI.
Yes, we use that too.
Okay.
Yes, we have
Okay.
that software.
So low MI and low MI.
Yes.
So it's an amplitude, it's a nonlinear, fundamental nonlinear. See, a lot of this terminology is the manufacturers have not have made it a little bit difficult for us. Okay, we all like low MI, but the reason the guidelines said very low MI is we wanted to emphasize that low MI can be hard, not very good sometimes. Like I showed you in that example where you can only see the apex because you're using a harmonic frequency. It really needs to be, I guess, the universal term. We say, are we using fundamental nonlinear activity? Because it's a fundamental transmit, a fundamental receive. You see here, 1.8 transmit, 1.8 receive, okay? That's the real key, because now we can see the basal segments. Here's the patient's 2-chamber.
We learned that from you last year.
Yeah, that's what I learned it like.
Now, look, here's the 2-chamber again. Take a look at this. And now look at this. This is just adding contrast. The entry wall is akinetic. Okay? And he had a 99% diagonal lesion. So you can see why that it was a proximal diagonal was supplying this whole territory. But because we're looking at some non-compacted border here, look how that kind of almost looks normal or deceivingly normal, okay? And that's why it's so important to, you really understand that what we try to pass on to our sonographers is if it's chest pain, you really don't think you've got really good delineation, do contrast because it delineates that non-compacted border, which was akinetic here, and would have not have been interpreted as that using the unenhanced study. So in this setting, we feel it helps. Several other examples here. This is an example of just a recent patient we had. An elderly woman with shortness of breath, pulmonary edema versus was a question mark. Was it the non-cardiogenic versus cardiogenic? You can see the unenhanced. This is transmitting now. This is a high MI, unenhanced image. So we're transmitting at 1.4, receiving at 2.8. We're getting some kind of ugly artifact in here, maybe a rib of some kind or something that I don't know, was rib shadow or something, creating that, but it's clearly interfering with the image. And so then we go, but the question is, does she have any evidence of coronary disease, that could be contributing to this? Wall motion didn't look too bad, but now here is that with the fundamental nonlinear, definitely we can see anterior wall contracts good, inferior wall, but here there's definitely a basal inferior segment. That's akinetic. But we couldn't see that well because we're here transmitting 1.8, receiving 1.8. Okay, so the fundamental nonlinear and MI 0.18, so very low, still getting good contrast. Now, if we used harmonics at this setting, we'd have very little contrast because we're transmitting at 1.8, receiving now at 3.6, and at a very low MI, you tend to see less and less signal, less and less of that harmonic signal. But when you use this nonlinear response, this really helps right here to see these basal segments that we couldn't really see very well before. So how valuable is that? Well, we looked at that in about 2,000 patients where we randomized 1,000 of the patients over a period of about 3 years to getting just standard resting and stress echo, and they came in with this chest pain diagnosis or shortness of breath or a question of CAD where they were going to be referred for a stress echo, randomized them to just regular echo alone, where they would only use contrast with harmonic imaging if the endocardial borders were not good, versus using the very low MI imaging approach all the time in every patient. So that we were at that time thinking, well, we're looking at perfusion, but what we found out is we were getting better wall motion. This is how we discovered that the very low MI imaging technique, which was originally released by manufacturers as a perfusion technique, and I don't know how come they even got away with doing that, because it's not FDA approved for that. But we were saying, well, maybe just adding that perfusion helps. Well, when we saw a resting wall motion abnormality, and this is before we did any stress, just like I showed you in the previous examples, that was the single most important predictor of outcome in these chest pain patients. If we see a resting wall motion abnormality when they randomized to this very low MI imaging technique, that identified a very high risk group for death and non-fatal MI, independent of outcome, independent of the stress echo outcome. While in the group that randomized to just regular echo, where contrast was only used for the harmonic imaging indication, and about 60% of the patients still got contrast for that, you see a resting wall motion abnormality was not predicted because it was missing them, okay? Because some of these normal, quote unquote, normals were ones that had resting wall motion abnormalities. Therefore, the groups were not significantly different if you had a resting wall motion abnormality versus not. So detecting a resting wall motion abnormality is very important, even in your patients referred for stress echo. And that's where this very low MI imaging technique is very helpful. That's why it got into the guidelines, because this was a prospective randomized study. So it received a 2A indication because it was one randomized study. First of all, like everybody says, just like we've all agreed on, ultrasound enhanced agents should be used whenever adequate segmental visualization within any coronary territory cannot be achieved. Yeah, everyone's agreed. Consensus of recommendation 1, level of evidence A, multiple trials showing that. But number 2, very low MI imaging with this nonlinear fundamental imaging is the preferred imaging mode and should be used with intermittent flash high MI impulses to, nothing about perfusion here, okay, to achieve homogeneous LVO and analysis of regional wall motion. And that's because we had this randomized study, it got a 2A indication. And here are all the different modalities. Some of you have asked me about what we use. We use this 3 to 5% solution of Definity. Or if we use Optoson, we use a 10% Optoson infusion. Or if we're using Lumason, we'll use a small bolus of Lumason between 0.3 and 0.5 mils of Lumason. These are all somewhat lower than what they say on the package insert because the very low MI imaging techniques are so sensitive to the contrast that we find that even just 0.5 of Lumason and then a slow flush works very well for giving us a nice period of time of perfusion that we can do that high MI impulse and look at regional wall motion. Or we can use these infusion techniques, which Definity has in their package insert. I don't know if Optoson has that in that package insert though. I think Optoson package insert is just bolus, right? Right. So it's still bolus, but we have used 10% Optoson as an infusion successfly.
Oh, Tom?
Yes.
Quick question. Describe what a slow infusion is.
I mean, well, that's like the 4 to 5 for Definity. We're typically running between 3 to 4 mils per minute. So in other words, they have it in about a 30 cc syringe, and they're kind of self-inverting it and then watching it go in over a period of about just like an infusion, 3 to 4 mils per minute for Definity, and that's about the same rate we used for Optoson in the Regadenoson trial. So. But it's a slightly more concentrated Optoson infusion because there we use about 10%. So that's where this stress. So what about stress? That was all rest, okay? So this is just typical examples. Like I said, I want to show a lot of examples because this it delineates what goes on day in and day out in our lab. I'm going to dangerously try to move back here to the slideshow because here's a 4-chamber view. This is a 58-year-old male, prior drug-eluting stent. But now when I saw him in clinic, he said he was doing okay, but then said he was using nitro about every 2 to 3 days. I said, well, that doesn't sound like you're doing real okay. Now, I don't want to make Nebraska sound like it's a drug abuse state, but and it doesn't even have marijuana approved, okay? But they pull a lot over from Colorado. It makes a lot of money for our state patrol. Because they just wait on the border, the Colorado border, for people to come over, and then they just randomly arrest people, and about 40% of the time, they have marijuana in the car. So, but as we know, marijuana, isn't necessarily the safest drug in the world, okay, if you smoke it, okay? We know there's some preliminary data showing that the Medicare numbers of ACS patients in Colorado is going up, okay, for one reason. It went up after marijuana got approved, okay? Not that I want to detract you Illinoisans from supporting that. I don't know where you guys are at in your state, but it's not approved here. But this guy had been using both, but he'd also been using more nitro, and then he had this history. So what do you guys think? So here's low dose. We always do an infusion about when they get a slight heart rate increase, because as I'll talk about in a moment, perfusion often will become abnormal before the wall thickening abnormality, but here just wall thickening. What would you say? At peak stress compared to rest, I thought it looked pretty good. Didn't see a whole lot. Wall thickening looked pretty good. But again, this is transmitting. Steve always wants me to talk about this because I want to just remind you, I'm transmitting at 1.8 megahertz, receiving at 1.8 megahertz. So we're looking at fundamental nonlinear response at a 0.18 MI. We never, ever have to go above 0.2 MI for this, no matter how big the patient is. This is the amazing thing about the technique, is that we're not transmitting a lot of energy. Okay, we're giving a high MI impulse. That's about 1.0 MI, but that's, as you can see, that's that little flash. You see, that's what, five frames. Okay, 5 to maybe 10 frames during stress sometimes because of the higher cardiac output. That clears the myocardium, so then we can really see the wall thickening. And I think right after you see the wall, right after the high MI impulse, you can see this territory here in the distal septum and apex. To me, it looks like it almost becomes akinetic.
You know, Tom, I would agree. Without your perfusion defect in the subendo.
Yeah, we're not. Yeah,
Oh, all right.
If you want to talk about, Steve wants to talk about perfusion, I do too.
Oh.
We're just talking about LVO
All right,
here,
all right.
okay?
I agree. It's more impressive.
So yes, and that's what we thought too. And here's two chamber. So I'll go to this again. I'll play this. Resting two chamber. Now we got a little foreshortening of the apex there, but sometimes we purposely foreshorten. That's another technique that I'm sure sonographers will talk about this afternoon, is that we purposely foreshorten a lot of times in this two chamber view, because we say, well, we're looking at the apex here, but we have a lot of trouble seeing the basal segments, even at that 1.8 transmit, 1.8 receive. So we will purposely foreshorten just so we can see these basal segments, because this is our little bit of right corner territory we're going to look at here, right? And this is our little bit of diagonal territory we're going to look at here. So we'll purposely move up in interspace, cut off the apex so we can see these basal segments a little bit better. So our sonographers have one view that's trying to do the unforeshortened apical two-chamber view, and then they'll have another one where it is the purposely foreshortened apical two-chamber view, just to look at these basal segments a little bit better. Okay, and then here is stress. Yes, anterapical, and we thought it even involved a little bit of the distal inferior. And we didn't really think the basal inferior was doing that good either. After that high MI impulse, as we inspected that and compared it to the rest, we thought this maybe wasn't doing a whole real good either. But again, why can we see that? Because when we give that high MI impulse, we clear the subendocardium. So suddenly now you're just looking at that subendocardial border, not the whole transmural border. And remember, that's where ischemia occurs, is in the subendocardium. And so now we see that little subendocardial layer that's not thickening. And so we said it was inferior and anterior and apical.
Wait, over here. I'm going to put the mic here.
Okay, okay.
Because for the streaming.
Okay, got it. Thank you. So we called inferior and distal septal and apical and distal anterior, as you said. And this, and then here's three chamber. We use these three views day in, day out we don't use the peristernal so much. We just use these views, especially during dobutamine. Now exercise will grab some of them as well. There's the,
I happen to agree with you on apical 2, 3, and 4 versus peristernal.
And there's the reach, and here again, looked like to us basal, a little bit infralateral was doing okay, but then this whole apex and distal anteroseptal distal septal mid anteroseptal was hypo. And then when we looked, he did go to angio because of the extent of the abnormality there. And you can see this LAD lesion was here, kind of in the proximal territory, right here. Can you see that? That's showing up, yeah. And that supplies an LAD that wraps all the way around. You don't see that part of it here, wrapped all the way around into the inferior wall. So this LAD was supplying a huge territory. And this is the key thing that we think the perfusion and the wall thickening abnormalities help us see is the extent of the abnormality that correlates a lot more closely with what we see at angiography. Not necessarily with FFR all the time, because we tend to pick up more abnormalities in FFR, and I'll show you the outcomes of those patients in a moment. But certainly correlates with stenosis severity. Now, again, just to focus a little bit more just on how you can take a study. This is basically taking a study that it was absolutely uninterpretable. This is a 62-year-old male, had obstructive sleep apnea, obesity, ankylosing spondylitis, was basically having chest pain after meals. And this was resting images here, okay? I mean, this very poor, okay? You would definitely refer this patient for nuclear if you had this and didn't have contrast, because you could not really see anything, right? I don't think anyone would argue with that it's impossible, okay? Because, you know, and we're transmitting at 1.4 mechanical index here, okay? Now, we go down to 0.18 mechanical index and go to, in this case, amplitude or power modulation, and look at the difference. Not only do we see this resting wall motion abnormality, you know, in this patient here that has an inflammatory condition, you know, now we're supposed to look at these inflammatory conditions as risk enhancers, right? No known CAD, but we know now he has CAD, right? You don't get a regional wall motion abnormality like this unless you have, you know, he didn't have any taco tubo, we didn't think like that, but he definitely has a resting wall motion abnormality that looks like it's in a territory of the LAD. Now that, the question is that viable even yet? Well, this is during dobutamine. You can see it probably becomes a little bit worse. But now we've gone from a totally uninterpretable study that would have required another nuclear study to be set up another day, as, you know, and, you know, followed up on how many days later. And a guy that probably was having significant angina. This was occurring after meals primarily. He was very inactive otherwise. Has extensive resting wall motion abnormalities, even more extensive and certainly more prominent during dobutamine. You know, and this was done the same day. This was done right after we got these bad windows.
Yeah, question. Am I seeing correctly? I don't have my glasses on. Is the focus at the mid cavity there? And if that, am I seeing the focus
Right
at
here
the
on this one here, focus is down here.
down there on the contrast images?
On the contrast images, no, we keep it down here. That's not a focus.
Okay.
The
Well, that
focus
was
is
my
still down
question
here.
because typically I know we recommend keeping that focus low, and from here
yes.
it looked like it was mid cavity. So I just want to
right.
clarify.
No, that's not. I'm 100% sure that's not the focus because we have everybody keep it at mitral
Yes.
valve level or lower. Thank you for bringing up that.
Yeah, I wanted to make sure there wasn't
Bring up that
anything with
point.
that very low MI that, you know, there's no focus or you change that.
Because if this is a good point, because if the focus is up here, then that 0.18 MI is going to be here, and then it'll drop off considerably here. So you want to keep that focus about right here at the mitral valve level, or even a little lower if you want, so that the MI reaches its maximum here. So you're getting that all the way penetration all the way down. Now there are some cases where people want to move this up maybe into the near field if they feel there's some cavity, some destruction here. But we routinely take our TG time gain compensations and give them a slightly higher position in the near field because there's a built-in compensation mode in the IE33 that was corrected in the EPIC. But we noticed that we still have to do it a little bit with EPIC as well, where you still have to turn the TGCs up a little bit in the near field to avoid some of that apical artifact. But good point. Yes, focus should be at the mitral valve level or lower. Here's the 3-chamber from the same person. The reason I present this case is he did have a very tight LAD lesion, proximal LAD lesion that was stented. But I think the point is that we can prevent a lot of delays in patient care by using contrast. Because we took from a totally uninterpretable image. I mean, like I said, I take you back to this first image, and there was just impossible to make anything out of this study. before the age of this kind of image, even if we had harmonic imaging, we would still be saying, well, we'd get a little bit in the near field, but we would not get these basal segments, which we want to look at too. We need to look at all the segments, right? And that's where this fundamental nonlinear imaging, this is his angiogram findings. I don't have the actual films, but you can see this was helpful in getting this guy appropriately managed.
So Tom, what would your interpretation of the images be? Because he had resting abnormality. You think it worsened for additional ischemia, or how would you put that together?
Right. So you have this resting abnormality, and this goes back to the viability issue in the setting of here. Now, what I didn't show here is during low dose. I think you can even see here, there's a little bit of augmentation in those segments in that are severely hypokinetic at rest. So we were primarily looking, does it still pick up a little bit during dobutamine infusion? And then we'll talk about the perfusion as well. I don't know if you can see that, but this started to replenish here. So we felt there was still some viable ischemic myocardium here. One, because in looking at perfusion, which we'll talk about in a moment, there was replenishment of contrast within this segment that was hypokinetic. Eventually, it was delayed, but it did eventually replenish. We thought there was definitely some scar, like right here. This did not replenish here. We called it a mixture of anteroseptal and apical ischemia with at least one segment of scar. That's the way we would have interpreted that. And then I don't know if the one thing that we were questioning also was this inferolateral segment, just in terms of perfusion. Sorry, I was trying to get this to play again. All right, is everything frozen here also? Okay, there we go. So we look at this resting area here that we thought the infralateral segment, even though the wall thickening was good, that there may be some delay in replenishment. And that turned out to be a 50% stenosis in that territory. But the LID was stented based on the fact that we thought there was some viability in there, and that it augmented one, and two, that we thought we saw some replenishment in there. If it's scar, it's not ever going to replenish, okay? Like this apical portion you see here, this never really ever replenishes. It's dark there. We'll come to that issue in just a second, and it stays hypoperfused. So that's, again, like I said, where we see this being extremely helpful, and this is basically our protocol. We give the infusion, as I said, typically we take a half a vial of Definity for the rest study and dilute it in 30 cc's of saline. This is in the 2014 guidelines appendix, and do the baseline images in these views. Then again, during an intermediate or a low level of stress, if we see resting wall motion abnormalities like we saw in that previous patient, and then again at peak stress. Similar to every other dobutamine stress echo protocol, you're using atropine to get to that predicted maximum heart rate, but this is what we use for that regional wall motion analysis. For exercise, again, we start the Definity infusion, in this particular case, Definity or Optison or a bolus of Lumison, 0.5 cc lumens of Bolson about 30 seconds before the patient gets off the treadmill or bicycle, and then do images after that. So this is just looking at coronary disease. But there's other circumstances where it becomes very helpful. Stress echo, as we just said. Here was a patient that just had a stent put in, and the question was, did the RCA wall recover function? We didn't know on the basis of the unenhanced image. This is right after PCI. It didn't look too bad, but then you can see here there's pretty extensive basal inferior wall thickening abnormality. Still there. What about here? There's an interesting case, okay? This was a person that came in about 6 months ago. 56-year-old male, chest pain, ST changes, trope was 0.11, went right to angiogram, had non-obstructive CAD. So the question is, echo was ordered to say, what's going on? What do you think? Use contrast, right? Right. So we use contrast. We use that very low MI imaging technique. . just for regional wall motion. This is still looking at just regional wall motion. I know we've had a few perfusion questions on this. It's fine, but this is still just in regional wall motion, regional wall motion. Look normal. What do you think? Sonographers, you guys are here now, right? You're doing the study. What do you think? Yes, right here. I think it's a very discrete abnormality here in the mid-anteroseptal. Doesn't seem to fit a coronary artery territory, right? Again, contrast, helps us see the regional wall motion. Remember, transmitting at 1.8 megahertz, receiving at 1.8 megahertz. Okay, the very low MI, fundamental, nonlinear. Well, so they did an MRI, boom, focal delayed enhancement. Here in that mid-anteroseptal segment, just where we saw they had to do the $3,000 test with gadolinium to answer that, but we could see it back here. Now, we couldn't say, even after the MRI, you have to say, well, that still looks like kind of like a subendocardial infarct there. We didn't know if it was a septal perforator or if it was prior myocarditis. But the point being, you can take a study that looks like this and change it to one that has not just helps you see things in general, but picks up discrete abnormalities in this basal segments, or basal to mid segment here, in this case mid segment really, that was clearly abnormal, had infarcted one segment. Now, we don't know why she did that. She didn't have anything. We went back and looked, was there a septal perforator that was him? We went back and looked at a septal perforator to see if he had anything there, but couldn't find anything. But clearly was an infarct when using delayed enhancement MRI. So, as Steve pointed out today, we have the issue of LVO for ejection fraction. This is really key. We know that helps. This is the slide he showed this morning, earlier this morning, where this is from Cleveland Clinic, okay, Margaret Park, Coco, who basically delineated these the volumes. You can see a significantly larger volume than what was seen by non-enhanced echo, but obviously dilated in both circumstances. But this has also been looked at in multi-center studies to see, can we do a better job when we add contrast to correlating with MRI and correlating not just ejection fraction, but with volumes. Now, Hoffman's group used low MI imaging, used harmonic imaging for this study, okay? This was not with very low MI imaging, okay? But even with that, you can see their volumes correlated more closely when they did 3D full volume contrast echo with a transmit 1.8, receive 3.6, okay, harmonic imaging at a low MI. They still had larger volumes, okay, and that were more closely correlated with CMR. But again, like I said, now that we're using the very low MI imaging techniques, our volumes are even almost replicating what we're seeing at MRI because of that non-compacted border. Okay, other LVO applications. What if you're doing here? This is a patient we recently saw transferred by one of our doctors in Denison, Iowa, which is kind of a small town right next to Omaha. Sent a patient over because they were questioning with something in the apex. Patient has a history of, I said, you see there, a history of a liposarcoma. So thrombus. I think it's thrombus. Okay. Well, you see, usually in thrombus, you'd expect to see a wall thickening abnormality with it, right? And that's the one thing as we're transitioning now a little bit from wall thickening to perfusion. One of the things you see those high MI impulses, we can apply those and see what happens to the replenishment within here. Is there any contrast? A thrombus is not going to have any contrast in it, right? What does this have? It seems like it picks up a little contrast there. And the best way to do this is to use a triggered end systolic frame just to kind of see that. But if you look at this, there's dark. And then if you look there, it looks like it's almost like the myocardium, right? And so this was the liposarcoma, metastatic to her apex, invading through the chest wall here into this territory. So not only can you see the perfusion of a mass, But this allows you to kind of determine, is it tumor or is it thrombus, especially when you have something in the apex. There you can see, this is those immediately post-HMI, and then here's a few beats later. So it has perfusion. A thrombus is going to stay just as black, okay? So this patient went on to chemotherapy and still doing okay today. So you would say, oh, that's disastrous. He's not going to make it. Well, this was 6 months ago. She's still doing pretty well with chemotherapy. But it leads us into myocardial perfusion, the thing Steve has been talking about. This I want to show at least twice, okay? Because of the data I'll show you in the next few slides, myocardial perfusion obtained with echocardiography is now being recognized as a very useful technique in several circumstances, okay? Not just in the circumstance of stress echo, which I'll show you, but also in looking at microvascular perfusion in a lot of settings. So Mike Main, as Steve pointed out, very nicely, worked very hard, met with Medicare, met with CMS, and showed them the data, and they approved in July 1, 2016, a add-on code. Correct me, anybody from the manufacturers, if I've got this wrong, but I think it's 0439T, CPT code. We've been using this for all of our perfusion studies now. And it's used as an add-on code for rest and stress, okay? Because as I said, it's very useful for rest imaging too, okay? As well as with stress, okay? For the assessment of myocardial ischemia or, Jim, as you put out, viability. It's useful for viability, okay? So you can add it on to any one of these codes. Now, this is a key thing. If you don't use it, Medicare has two ways of moving this up, because right now it's an add-on code category 3, okay? So that means it's, only probably reimbursed by maybe third-party carriers. How does it get moved up? What I'm told is how many people are using it. So if you're doing perfusion, like some of you said are doing, you definitely should be adding this on as a code as a means of showing people that we are using that data. How are we using that data? Well, we're looking at these end systolic images. Why do we look at end systolic images or near end systole? Because that's when it's purely capillaries, okay? If you look at other parts of the cardiac cycle, you have both arteriolar and capillary input that are causing that signal. If we're going to track coronary disease and assess for coronary disease related abnormalities or microvascular perfusion, we need to primarily just track the capillary blood flow, and that's what the end systolic images allow us to do. So we measure that signal. We don't actually do this, but we analyze it visually. But I showed the slide to show you what it actually looks like if you were quantifying this in any one of the segments. You'd see that after that high MI impulse, the myocardial contrast disappears, then it replenishes. Under normal conditions, if myocardial blood flow, if microvascular blood flow is normal, and we're using the typical two-dimensional transducer that has about a 4 millimeter elevation plane, capillary blood flow is about 1 millimeter per second under resting conditions, and all of us sitting here in the room before lunch. Now, if we went out and climbed the steps up to the 59th floor, we would probably be replenishing, we should be replenishing at 2 seconds following a high MI impulse. It should also do that for any form of hyperemic stress, dobutamine, adenosine, dipyridamole, all the agents that nuclear has been using for years can be done, and only looking at the myocardial blood volume. This is all nuclear looks at right here, myocardial blood volume. It does not have the ability, because it doesn't have the frame rates, to look at this replenishment like you can at the bedside, because you can give this high MI impulse, and this replenishment correlates with the red blood cell velocity, which is one of the key components of blood flow. This plateau intensity correlates with capillary cross-sectional area. Because we can look at both the replenishment and the plateau intensity, velocity times cross-sectional area, we can look at centimeters cubed or milliliters per second myocardial blood flow. And so this is a bedside technique that you can use to look at myocardial blood flow and its changes in response to a stress. So that's why we do this too, give that high MI impulse, is look how rapidly does this replenish. So we don't necessarily do any quantitative data. We look at the bedside while we're doing these stress studies, how rapidly does that replenish? If we have a question, we go back and do what we see on the bottom screen here. We go back and just roll back on the screen and look at these end-systolic images in in the first 3 seconds or so after the high MI impulse, and that helps us a lot in an area where we're questioning where is wall thickening abnormal. Perfusion will clearly be the first abnormality you see before wall thickening. So if perfusion is normal, wall thickening will be normal. So that's why we use this technique day in and day out as an add-on to our wall thickening abnormalities. So I'll show you just a few examples of that. And here is we get almost all of our liver transplant evaluations, no matter what their risk factor profile, they tend to come for stress echoes. And you say, well, that seems kind of stupid. And we think it is a lot of times because they have so few risk factors. But occasionally we see a case like this, and we say, well, maybe we should be doing that. This was that patient I just showed you. She had tough windows, 45-year-old, alcoholic cirrhosis, and they wanted a stress echo. And we stopped arguing with them. We just go ahead and do them. But after this one, we really didn't have much, had to say. And I'm going to go out of this so I can play this. I apologize again for this. So again, you see pretty poor windows. And so we would use contrast for the LVO indication anyway. And then, though, when we did stress, I think you saw this already a little bit here. Here's our rest images with contrast, good wall thickening, kind of that hypercontractile state you see in a liver patient. But look at that. What are we looking at here? Well, you can see the wall thickening abnormality. We've talked about that already. But there is no replenishment after that high MI impulse in the distal septum and apex, whereas under resting conditions, clearly was replenishing. So this is we felt a pretty severe abnormality because it was both wall thickening and perfusion. About 27 to 30% of the time, we'll see just the perfusion abnormality. But here you can definitely see the wall thickening abnormality. And this patient has serial mid-LAD lesions at angiography with an IFR of 0.36. Okay, remember 0.89 is normal for IFR, the resting flow reserve. So this was severe lesions in her LAD. And that is why in the guidelines, we gave myocardial perfusion a 2A indication, because it although not as much data available on the enhancement of wall thickening like we had for enhancing LVO, we felt there was sufficient data based on several trials that I'll just quickly show with a couple of them to you. There was evidence to suggest this was adding additional information. Why is that? Well, because there's 2 circumstances where we may need perfusion in addition to wall thickening abnormalities during stress echo. One, we already talked about improving regional wall motion abnormalities, but what about myocardial perfusion? Well, here's one circumstance, okay? This is a patient that has, here's the end-systolic rest perfusion, end-systolic stress perfusion. I show these end-systolic images just to show the wall thickening here. Also, wall thickening, we thought, during the 30 mic infusion was still pretty good, but look at this, there's no real replenishment going on here. Well, we thought there was during rest. And here we are at really 30 mics, 0.3 of atropine. No real replenishment. This is about 2 seconds or 3 seconds after that high mechanical index impulse. This was an 80% circumflex stenosis, okay? So even at peak stress, there are situations where wall thickening still stays pretty close to normal. Now, I think when you look at this maybe a little more closely, maybe it is a little hypokinetic, but there's clearly a perfusion abnormality. And we did not see any replenishment. And remember, it should be within 2 seconds during dobutamine stress. Now, this circumstance. Here's a patient that had a prior heart transplant. and was referred for stress echo. It was kind of the routine. I think she was about 3 or 4 years out. So it was just in her 20s. This is during intermediate stress. Remember, I told you we always do some imaging during intermediate stress. There's resting apical 2 chamber. Again, this is about 2 seconds after the high MI impulse. And here it was just during a 20 mic infusion. We had already given 0.8 of atropine, but there was really not much heart rate response yet. And look at that whole anterior wall. Even though wall thickening still looks pretty good. Following the high mechanical index impulse, virtually no replenishment. Well, we had pretty good replenishment under resting conditions. See here? Wall thickening still pretty good. No LAD. LAD was totally occluded. Transplant vasculopathy. In a relatively young person. But again, you can see how you can look why this intermediate stage is so important. Perfusion abnormalities sometimes annotate the wall thickening abnormalities and give you a heads up during the study. If you're a sonographer and you're in there doing the imaging and you start seeing no replenishment at that stage, you better be very careful because you're dealing with a fairly significant lesion when already at this relatively intermediate stage of the test, you have a fairly significant perfusion abnormality. So this is where we think it was helpful. In that that prospective study I discussed with you about the resting wall motion abnormalities, the stress abnormalities in the patients that were randomized to the very low MI, fundamental nonlinear imaging technique, an abnormal study shown here in the blue had a significantly worse prognosis than an abnormal study with just using conventional stress echo, where contrast was used just with the harmonic imaging mode if necessary. So you compare this with the PROMISE trial. Remember, the PROMISE trial compared CT to radionuclide imaging or stress echo, okay, and saw no benefit. Here, if we added a vial of contrast to every stress echo we did, we had a much more predictive study than just a conventional stress echo. So this, unlike the PROMISE trial where everybody's trying to promote now everybody should be getting a CT scan to evaluate chest pain in the ED, okay? And there are literally some people really trying to promote that, let me tell you. We have data that shows that if we just do a contrast study with perfusion and wall thickening, we do a lot better job of predicting outcome. And so I think this is data that really needs to be emphasized, when we talk to our third-party carriers, in terms of what's the most cost-effective way of dealing with the patient presents with chest pain. You can, as we said, quantify this. Wilson Mathias and Gianni Susui have actually quantified that replenishment. And that does seem to add some value to just our qualitative interpretation, like I told you about, where we do 2 seconds during stress and 4 seconds during rest. If you add this quantitative measure of analyzing the replenishment over time, they did show that you could have an improvement in your detection of coronary artery disease. The problem is, for us, is that it's just too time consuming to try to do these end systolic replenishment curves at the bedside of all the patients we're doing. We think we're getting a lot of data now, but should the manufacturers find better ways to do this quantitative technique, either through AI or through techniques that allow us quickly on cart to do these kind of measurements, I think we'll get even more data that shows the ability to detect coronary artery disease. But as we know now that since we have an optimal myocardial blood flow technique, radionuclide imaging has always been a compromise, right? Not just because of its cost and radiation, but its resolution is quite poor. It's around 12 millimeters. So basically, if you have anything that causes myocardial thinning, you're going to miss defects by partial volume effects. While myocardial contrast echo has about a 2 millimeter resolution, so it can pick up wall thickening abnormalities very easily. Because remember, your normal wall thickness is about 10 millimeters. If it's dyskinetic, it can go to 8 or 7. Well, that would be missed by radionuclide imaging because it doesn't have that resolution. It can't pick that up. It's going to average in the cavity with that myocardium and make it look like it's normal. Well, myocardial perfusion echo is going to pick that up and allow you to do it during any kind of vasodilator stress. If you don't want to do dobutamine, You have the capability of doing this during dipyridamole. Roxy Sr. Just took a band of European physicians, okay, and taught them real quickly how to do myocardial contrast echo, okay, using that replenishment technique, not a quantitative technique. Just said, okay, just look for replenishment during dipyridamole. See if it occurs within 2 cardiac cycles. He just told them just do it. If it doesn't replenish within 2 cardiac cycles of your high MI impulse during dipyridamole infusion, that's abnormal. They just learned a very simple technique, okay? Compared it to the long-standing accepted standard of radionuclide SPECT, okay? And 600 patients, okay? And the sensitivity of just using this myocardial contrast echo technique with very low MI imaging, and here they're just looking at perfusion. They don't really have much for wall thickening. They looked at wall thickening, but remember, you don't get the wall thickening abnormalities very much during dipyridamole or adenosine, okay? But look, sensitivity was significantly improved in single vessel disease detection using just this visual analysis of replenishment compared to radionuclide imaging here. Multi-vessel disease was not different. They both did a good job of picking up multi-vessel disease, but proximal stenoses that were more than 70% in diameter picked up better, sensitivity better in patients that had an MCE. They both got the same test, but they was picked up better on the MCE technique, the real-time myocardial contrast echo technique. And it was independent of vascular territory, LAD, circ, RCA, because we don't attenuate in the far field with this technique. So we can see perfusion in the distal territories. Therefore, we gave this a 2A indication. The study group, or the group that was set up for just looking at all the data that was available. So it's not a class 1 technique. No one's saying, oh, go out and you must do it. But I think you can see from here that it probably has some beneficial effects if you learn the technique at the bedside. Certainly for wall motion, if you just want to learn for wall motion, it definitely will help. It can be done with dipyridamole if you want to do that. We have dipyridamole in this country too. For some reason, we don't ever use it. We've done it with regadenoson, with Optison, and Definity. We did a study with Mayo Clinic. Sharon Mulvey spearheaded that trial, and we found it to be very helpful for detecting coronary artery disease. Just using a 4 milligram, it's a 4 milligram regadenoson bolus, and then just imaged in the next 2 to 4 minutes. So it was literally not much more than a 10-minute stress test for the patient. And it correlated very closely with angiographic findings in that study. What about this? Here's what we're talking about. Resolution. 10 millimeters versus 3 millimeters, okay? These are your 2 perfusion techniques that are readily available. You can say, well, MRI is available. Well, yes, it is. But, you know, get real, okay? Do you really think you can do MRI in a large scale study? Probably not, because I do MRI. 40% of the time we don't ever get the study done, okay? They get claustrophobic. They don't, you know, you can't get good data. And the adenosine perfusion data isn't that good, but the problem is it's just not that available. You can't take a patient coming into the emergency room, okay, can I get a stress MRI? Yeah, we got to put it on for tomorrow, okay? Now, some labs are very, you know, responsive, but it's not something I see as being, you know, available like SPECT or RT-MCE, okay? These are the bread and butter techniques, right? But look at this, okay? Do we get a stress EF from SPECT? They report one, but is it truly a stress EF? It's not a stress EF. They're doing the EF 20 minutes after the patient stopped or got off the treadmill. So it is not a stress EF. We get a stress EF when we do perfusion echo. We get it on, we report it on everybody, okay? Dobutamine exercise. But you're not getting one with radionuclide SPECT, okay? You are getting prognostic data with both, okay? The resolution, as we said, is dangerously poor for SPECT, okay? Now, it's better with PET. It's about 3 to 4 millimeters with PET. But again, we're talking about a much more expensive technique in that setting. Diastolic function. When's the last time the SPECT study gave you an assessment of diastolic function? We have cardiology. You guys tell me. They never tell you that, okay? We report that all the time on our stress echoes. Yet, we get this much reimbursement if we add all of our reimbursement schemes on there. And look at this. This is what the patient gets for a SPECT study. In addition to this little add-on, 15.6 millisieverts. Okay, that's just a technetium-based study. What about the patients that have normal coronaries? Okay, where we still see these perfusion defects. We have a sizable number of those. Shelby Cuddy, our pediatric cardiology of all people attending, helped us with this study. We looked at death and non-fatal MI following abnormal capillary perfusion stress in patients that had a normal angio, just published this in Circulation CV Imaging. This green line is the people that had coronary artery disease after their abnormal stress perfusion echo. These are the patients that had no coronary artery disease, the red line, after their normal perfusion or abnormal perfusion stress echo. And then these are patients that had a normal perfusion echo, but still went to angiography. So we knew what their angiographic findings were, okay? So that's why it isn't like a real, like you typically see with the normal studies that are really, really, really good. Well, these are people that still went to angiography. They had some other disease process. And we're looking at death and non-fatal MI. Look at the group here that had normal coronary angiogram. By 3 years, their death and non-fatal MI rates were the same as those that had abnormal coronary disease. So there is truly microvascular disease, okay, that occurs in the absence. We know microvascular disease occurs in the presence of coronary disease. Now we're learning that microvascular disease occurs in the absence of coronary disease by epicardial standards. And we're seeing that these patients have a bad prognosis, okay? And the question is, do statins help here? Do anti-inflammatory agents help here? That's what we can now study because we have a good microvascular perfusion technique. I show this again because I think we have to emphasize and educate, just like ICUS. The goal of ICUS is to educate. Well, our goal should all be to educate because we have a very, 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 very good imaging technique. It's getting better because we're learning about how very low MI imaging works, how it can help us at the bedside. Our sonographers do only very low MI imaging now. We don't do it in low MI imaging for nothing else. Now, Philips has changed because of this, has changed on the Epic platform. Their low MI now, if you notice, is now 1.6 transmit and 1.6 receive. So they now have changed the old low MI where our harmonic mode, they've gotten rid of the harmonic. You can get a LVO, or their LVO now is using the fundamental nonlinear. So check that out. All you have to look for is to see the little circle that Steve told us to look at there. What's transmit, what's receive. They should be the same. And Philips got the message. Hopefully GE in the room, hopefully. Hopefully Siemens in the room. I don't know, Siemens in the room. Toshiba, are they all here? Hopefully you get the message, okay? Help us, okay? Because we got a technique here that's going to be very helpful, okay? It should be, within 5 to 10 years, the standard for stress imaging. And because of its availability, because of its accuracy, because of its predictive value, because it provides an ejection fraction, a rest and stress ejection fraction. It immediately looks for other abnormalities, okay? When's the last time we ordered a patient for a radionuclear stress? They said, oh, did you know he has a dissection? Okay, or did you know there's significant mitral valve disease? Or do you know they have really bad diastolic dysfunction? Never, okay? We always do that for stress echo.
Tom, what about 3D?
Well, that's what I was looking forward to spend some time looking at the vendors.
Have you done it?
No. Now, Philips is finally really ready on the X5. Now, the X5 is still pretty fat of a face, okay? So we have people that, with small rib spaces that, make it a little difficult, okay? I heard they're working on that, okay? But it's finally at the 1.6 megahertz transmit, 1.6 megahertz receive, giving us good images. And we're going to start doing biplane, and then we're going to transition that to the 3D acquisition. Because I think you're right, that's probably going to be the ideal completion. That's the thing about, echo, it just keeps getting additional benefits, okay? Hopefully within 5 years, we'll be able to do strain with contrast, because strain is great with great windows. Strain is impossible with bad windows, in our opinion. And we need something that helps us get a better window so we can do strain, okay? So I think contrast has a capability of doing that. Maybe that post-high MI impulse, remember, that's when we clear the myocardium. That may be the ideal time to do a strain if we can get the software to work for that, because we have one cardiac cycle there where even in normal perfusion, we usually have almost totally black myocardium, so it would be perfect for getting the bubble interference out of the way of the myocardium, for strain analysis, and giving us the endocardial border delineation that we need to make sure the tracking mechanisms stay where they should. Yes, so we'll turn the lights up, Steve, we'll take some questions there.
Does your software automatically drop down MI to 1.0?
Could you repeat the question?
We get the microphone. The question was, does our software automatically drop down the, what are you talking about, the MI or the frequency? MI. Yes.
What do you have to do to measure?
We can preset our system, and I think the low MI on the Philips does preset to 0.18. Now the problem on the Epic we saw, yes, it presets to 0.18, but it sets the flash to like 0.5. And that's not going to do a real good job of clearing the myocardium in certain circumstances, especially during stress. So we had to preset that up to 1.0 again. So the flash MI, remember on the upper right portion of the screen, it gives you the MI and then the flash MI. Now the MI around 0.18 seems to work for the Epic transducers, the newer versions. But the flash MI, we had to adjust back up to 1.0 to get good clearance.
So is it a time to introduce the term smart to software manufacturers so it could drop down MI automatically, just detect it and sense it?
Yeah, I think that a lot of the AI looking at what it's receiving, we got Philips at one time to actually send us thank you. The question was, you want to state your question again?
Is it time to introduce the word smart to software manufacturers?
Yes, so the question is, could smart technology help us? Yeah.
Could detect it automatically, just drop down MI?
Yes.
To what I want to see, especially.
Right. Again, like I said, it would take probably a little learning time for that, but it would be, I think it definitely should be able to tell us what's optimal MI to reduce tissue signal. And also hopefully could do some of the gain adjustments, because we have to do a lot of gain adjustments during our stress imaging. You know, we go to dobutamine stress, and a lot of times the image just for some reason appears brighter. So we have to turn our gains down a bit so that the key we always tell our sonographers, make sure your post-high MI impulse, make sure there's contrast in the myocardium before you apply a high MI impulse, and that the post-high MI impulse clears the myocardium. Because it's not just something that, you know, I literally will get into a mode where they're just flashing just to be flashing. The key thing is the purpose of that is you have to see contrast there first. If you see it, then flash it. It should clear. If it doesn't clear, you probably have some signal from tissue there yet, where you could either adjust your MI or adjust the gain a little bit so that you still are getting clearance of the myocardium so that you can visually analyze that replenishment. So yes, I think all those are programmable.
And it saves time.
Yes, yes.
In the stress situation.
Right. It should have that ability to do that. And so I think that's very doable. In fact, there's people, I think, working on that even as we speak.
And the second question, how do you follow up on this CBD users now since the legal, after you detect some wall motion abnormality? Are you calling interventionist immediately, or you recommending any additional studies and tests?
Typically, we have two choices there, depending on, like, for example, I have probably about 50 patients that didn't have that LAD territory defect until like Bruce 4. And so I've been following them for about like 10 years just on medical therapy, high dose statin, aspirin for secondary prevention, blood aggressive less than 130/80 blood pressure control, and they seem to do fine. But then if it happens in Bruce 2, then typically we'll resort to an intervention. Not sure if that's really helping, but usually that's kind of our cutoff, is that if they can get to Bruce 3, we'll just manage them medically. If they only can get to Bruce 2, then we usually do an interventional approach if feasible. But no, we don't do any additional testing. So.
You're recommending it in your echo read, right?
Yes.
Thank you.
Yes.
I'd like to share a consult that I got. Getting back to your idea of comparing nuclear with stress echo, I I got a patient that came in with chest pain that had a nuclear study. Here's how it was read out. Normal perfusion, probably normal, cannot rule out triple vessel disease.
Yeah, because they're afraid of this quote-unquote balanced ischemia.
Right. So I did a stress cycle on it.
Right, which has always been something I've been unable to understand because I've never seen someone have a perfect RCA and left main lesion that looked like it was exactly the same. So I think the problem is, just like we said, it's more an issue of counts and whether they're getting adequate counts in there. I mean, I do nuclear and I hate doing it, but that's what like our EP doctors think that, we got to have a nuclear. Why is that? Because our practice bought a camera. Okay, that's why they think they need to do a nuclear. Not because they think it's a better technique. It's all about, well, if I'm going to pay for this camera, we better be using it. Okay, and so they'll accept the fact that this could be totally wrong. And we have several cases, literally in the last month, that just like you described, where there was a left main lesion, and it wasn't the counts because they were so low because of all the subdiaphragmatic activity. It looked normal. It clearly looked normal. And I don't see I've never had someone in literally in the 15 years that we've been doing perfusion echo with continuous infusion perfusion imaging come back and say, did you know you missed a left main lesion? But literally in the last month, we've had at least 2 cases that would happen to the nuclear. It's not a very good technique. The problem is it's reimbursed very well. And so it's a driving force behind why we're still doing it. It's a sad testimony to what we're doing to our patients. Yes.
So I was here last year and I went back and I had Philips add the multi-pulse very low MI onto all of our equipment. So we have 2 Epics and 4 CVXs. And so that is an add-on software.
CVX is your...
It's the newest Epic.
Okay, yeah, that's the version that... Yeah, because the first version of Epic was horrible that they sent out. We just had so much trouble getting to try to reproduce anything that we were getting with the IE33.
I know you like the IE33, I remember that last year, but we have success.
Yeah.
We have 2 IE33s left over success. So that was an add-on software that I had to request. So, you can't mimic the very low MI, correct? Mimic it without the software being on it.
Yeah, it has to be there, right? But the good thing they did on Epic is they put it also on their so you can literally do perfusion imaging on their LVO application now.
So ours toggles between LVO and very low MI.
Right.
We can choose which one we want
Right.
to use.
Right. And so the key is on that is don't get caught up in the nomenclature there because I would just look and see what your frequencies are.
So I look at we make sure we look at the very low at the fundamental imaging. So my settings for perfusion are 0.18 for the low MI, and then at flash we're at 0.78. You think I should pick that up?
Well, if you're getting clearance, like the key is if you're getting clearance, that's probably adequate. We had to turn ours up to around 1.0 before we felt like we were getting consistent clearance. We still, with the Epic, we had a lot of problems with artifacts and gains. So we had the gain, we finally settled on a gain that's probably around 70 to 75%. That eliminates some of the noise in the signal. We still have to turn the TGCs up just a little bit in the near field, even though it's supposed to be designed to be not have to require any adjustment. And then we turn the MI up to about 1.0, and we use typically 5 frames. Again, we vary that based on what we see in the cavity and what we see in the myocardium. If the myocardium clears with 5 frames, there's not much cavity destruction, good. I mean, there's always some patient-to-patient variability there. That goes back to, like you said, the smart imaging approach there. But if the cavity, what we tell our sonographers is if you're getting clearance of myocardium and no cavity destruction, we'll take whatever frames you need to do that. And sometimes during peak stress, we have to go up to like 10 or 15 frames to really see the myocardium clear. I think just because of the rapidity of the blood flow at that time. But yeah, there's a little tweaking, but once you get that, then you can preset that and then it should stay there for you. But we feel a lot better about the Epic now than we did a year ago. So I don't know what your experience has been. So.
I mean,
It does.
Yeah, it's like a computer, it's sensitive and it freezes. We
Freezes.
have a lot of freezing issues.
Yeah, so we need industry to, I'm glad they're here. Thank you for getting them here, Steve. Because we really need to have them focus on, we'd like GE and Siemens and Toshiba to really jump in there like Philips has done to make this more of a universal application. Because who's using Siemens and GE primarily? You guys use a lot of GE, right? And see, what do you have a 1.8 transmit, 1 point receive, or a 1.6 transmit, 1.6 receive, a fundamental nonlinear? I know they have it on their system, just I don't.
But we haven't started the perfusion yet.
But even just for LVO, do they have that for
Bring it
LVO?
down, yeah.
They do have a fundamental nonlinear technique?
Yes.
Good. We'll have to spend some time looking at that, because GE really needs to do that.
By
I know
the way,
Siemens
Tom-
was gonna resurrect the contrast pulse sequencing again.
Sequoia, yeah.
On the, that they used to have on the Sequoia. They were supposed to really release that, but I don't know where that's at. We have to ask Marty, or someone.
Tom, I'm actually watching you live. This is streamed, you know. I'll have to show you your images. So
Oh, I don't think I want to look at them.
George is doing a great job. Can I just have a hand for him?
Yes, good job, George. Still got to work on our presentations, though. But
Now, we had a request that we serve pizza today. We are. It's here and it's hot. So why don't we take a break? Tom is going to stay on. He's not rushing right back.
no. I'm
And
here
then
all afternoon.
we're going to, right after lunch, and what is it, 12:15? Let's start around 1, because if we can move things along, we'll get out of here a little earlier. Then we're going to have a lecture by Joy and Jessica. Then Tom will talk about
Therapy.
therapy,
CEUS.
and I'll do carotids, and the day is ended. So let's come back here at 1, and let's all eat some pizza and talk to Tom in the meantime. Thanks.